Hello and happy Teach Me Tuesday. My name is Lisa Houston. I'm an experienced NICU nurse educator here to bring you another topic broken down. It is still NICU Awareness Month. September is NICU Awareness Month, where we focus a lot on families and spreading the word of what the NICU is and celebrating NICU nurses. We just wrapped up NICU Nurses Week. And today we're going to talk about death and remembrance in the NICU because the end of this week is NICU Remembrance Day. This is also something that has been asked of me to cover. I do think it is a little more nuanced than maybe even other things that we do in the NICU because it is so personal and every unit is going to be so different in kind of what their setup is for this. So I have the slides here for you. I am going to tell some personal stories and kind of go through how I would handle certain things. So this is going to be a little bit different than our usual, but I do want to give you some resources. And in my social media this week, I'm going to be sharing some resources. So if you don't follow me on Instagram, join me on Instagram where I will go through a couple of resources that I find helpful in this. And we are also going to end with a little pep talk about self-care for nurses. So that is our plan today. I think that one of the things that catches people off guard in the NICU is that first death and that babies die, and it is tricky. This is not an easy thing to talk about, to educate about, or experience in any way, shape, or form. As a nurse, I do feel such a sense of privilege when I am with a baby and their family in their last moments because this is when they're the most vulnerable. And if you're able to support someone through this, while it is devastating and hard, we really can impact their future and what we're doing. So I do think of this as a privilege, as part of our job. Does not get easier. I'm going to be honest with you. I will say that some things in the NICU, like your PIVs, your lab draws, those tasks type of things do get easier. I even think parent education gets easier. This doesn't. So I also kind of warn people that are thinking about the NICU about that. So just something to think about as we go through today. Here are some statistics. You know, I love facts on neonatal death. This picture from the CDC is the most recent. It's from 2022. It does talk about the number of infant deaths per 1,000 live births spread across the United States. In the United States, in 2022, it was about 22,000 newborns died annually. That can include from SIDS deaths and maternal complications that lead to the death of the infant. For infants that are born live, we have things such as prematurity and the complications of prematurity, congenital anomalies, birth defects, sepsis, infection, and then birth asphyxia that can lead to pulmonary hypertension that the baby cannot recover from. Many NICU deaths, in fact, I would say the majority of deaths that actually happen in a NICU follow a transition from intensive care to comfort care. And we're going to talk a little bit about what that means and how we can support babies through that. So yes, there are going to be babies that die at birth, and there are going to be babies that die within the first few hours of birth. And then, of course, we're going to have our babies that maybe live for a little bit and we do code on, or those babies that we withdraw care for per parent's request. And I think it kind of falls in there with everything a little bit in between. What we can do as nurses is to really have, nurses and the whole care team, is to have this clear communication, to explain to the family, like, it's time to go from caring, intensive care, to comfort care. And what can we do to help facilitate that transition for you? As we withdraw support, asking the parents, when do you want the ventilator off? When do you want the monitor off? When do you want the IV drips to be discontinued? Do you want to hold the baby and then do each of those things? And I have never received the same answer twice. Some families want everything removed except for the breathing tube until the baby is in their arms. Some people are the opposite. They want the breathing tube out so that they can see their face, but they want the IVs going until the end. So there is absolutely no wrong answer. The only wrong answer is that which we force upon them. So whatever we can do to help them. With the environment, making sure we can silence the alarms. Almost every monitor will have a kind of a comfort care and end-of-life care setting. So find that on there. It's a profile you can turn on so that it will not alarm when the baby's heart rate is dropping. Get your lights dimmed. Offer a private room if you don't have a private room, if you're in an open base setting. And then think about comfort measures. Do we need to do anything for pain control? Getting warm blankets over the family, getting them chairs to sit in, oxygen if it's helping with breathing, breaths, etc. And then obviously having the parent hold their baby. I've had parents that couldn't do that, and that's okay. I think one of the worst things that we can do as nurses is to judge what a parent is choosing, because we're not in their shoes. And maybe we've experienced something similar, but we're not in their shoes. So whatever it is that they're choosing in that moment, we have to support. And I have also been in situations where the family did not want to come at all, or they couldn't make it. And in those situations, nurses will usually hold the baby, or a provider will hold the baby so that they are not in a bed during their passing. And so that's something that if you are comfortable, you could offer to do for the baby. As the baby is passing, some things that we really need to do is to prepare the family for what to expect during that. I think that's one miss that I've had in my career, where I just didn't expect them that the baby might still breathe, or not expect them. I did not explain to them that the baby may still breathe, and you're going to see some changes in their color, and some fluid may come out. And the baby may make some noises, some agonal breathing noises. And I have learned from that that is something that we should be preparing them for. Additionally, as lines come out, the baby could have bleeding in that area. I do think it's important to talk about potential for bleeding. I have seen that pulmonary hypertension, not pulmonary hypertension, pulmonary hemorrhage, some bleeding happen after the vent is turned off, because we've kind of kept the capillary beds at bay, and then we turn the ventilator off, and some bleeding will happen. So if you had a baby who is at risk for that, I would be prepared for that as well, and maybe suctioning before you get the baby out. After the baby has passed, some things that we can do is to offer to make any memory making, to sit quietly and hold space, to use our language, get them their water, their blankets, meals. There's usually complimentary meals they can get. Visitors, who do they want at the bedside? Having the chaplain there. I cannot explain to you how much I value chaplains, and not for like a religious point, but just having that person who maybe wasn't involved in all of this care to come and be with the family. The chaplains are non-denominational. They may present as a certain denomination, but they will do anything for families. Hospital-trained chaplains are some of the most unique, amazing people I have ever met in my life. And you will have a rabbi come and sit with someone who's got their Bible open, and they don't care. They are totally in for it. So if you have chaplain services at your center, please get them involved in this process. And again, I'm going to go back to, there's no wrong answer. So if a family does not want mementos, if they want you to make every memento, if they want to stay for 24 hours, there is no wrong answer. The wrong answer is that which is not supporting them. So if they don't want pictures, that's okay. If they don't want mementos, that's okay. Usually people are going to fall in the middle, or they'll say, can you do it after we leave? Or they'll say, can you do it? I'm just not sure if we'll pick it up. And that's okay too. So that's kind of the gist of that. This is a very basic slide of what you can and cannot say. I think we have better ideas of kind of what we can say, and I want to remind you that silence is okay. It's okay to not have something to say. So saying things like, your baby is beautiful, I'm here with you, it's okay to cry, I'm here if you need anything, there's no worry process, whatever you need, I'm here. I will sit here. Do you want to be angry? You can be angry at me. I've said that to a family before when they were feeling really angry. I'm like, yell at me. I'm ready. Like, I will take that on for you. I have been with them as the baby is passing, and they wanted silence in the room, and that's okay. It's okay also to be a gatekeeper in this situation. And if other people or other families members are saying things that really aren't helpful, and that comes down to those at least statements, at least you can have other kids, at least you can get pregnant, at least you have other kids, at least you had blank amount of time, a week, an hour, whatever it is, at least they're in a better place now. Like, just avoid those at least statements. They never come out right. And we don't know anything. Just because you've been pregnant once doesn't mean you can get pregnant again. Nobody knows that. So avoid saying all of that. And of course, coming in with your cultural and spiritual sensitivity. And again, this brings in that chaplain or cultural liaison. If they want their baby baptized, if they want a rabbi there, some units have stricter visitation rules. This is one of those times where we got to break the rules and get somebody in here. I remember that happening during COVID. A baby was passing during COVID. We had a 2-parent visitor policy, and that was it. But we made exceptions, right? We made exception for the priest to come, and then additionally for other family members to come in. So asking them, are there any traditions or rituals that are important to your family? And if there are, honor that. Do what you can to help them. And make sure that we are doing that in the most respectful way. And hopefully that they're going to do it with you. These are just some possibilities. There are so many. I have worked with a family once, and we made a mold of the baby's hand in the mom's hand. Like, we put them in together because she wanted it to look like the baby was holding her hand. Totally fine to do that. I had to cut a lock of hair off a head that barely had hair, but they wanted a few pieces of it. All the little things in the bed they wanted, like the pulse oximeter and the ID band and the blood pressure cuff. They wanted all of those things. The handprints and footprints, we've put them in books before. We've put them on paper that parents have then gone and tattooed on themselves. I'm sure you've seen some things like that before. We have used things for children. I will go into that a little bit on the next slide, but really, there are a lot of resources out there available. And what I will say about this is every unit has an expert in something, and every unit probably has an expert in this. Someone who is passionate about it. You can actually get a certification in it. I worked with someone on my old unit that did that and went to a conference on this, which I just loved that. I mean, it's just like such a unique situation. Who then kind of spearheaded the revamping of our supplies and what we were doing and our teaching and our forms and everything that we had for families that are going through this. Additionally, trained a few other people who really wanted to be champions at this end of life care. And that is another way that you can, escalate yourself within your unit. If you're looking for a growth opportunity, this is another one, because sometimes there are people, that are, trained in it, but B, maybe they just feel better about it. Or maybe you need like a crafty person. I don't know if you know this about me, but I cannot draw, and I have horrible handwriting. I am never going to be the person that's going to make a certificate of life. I'm going to go find someone with like better handwriting. Maybe you have a great photographer on your unit. Maybe you've used something like Now I Lay Me Down to Sleep to come and help take photos of this. Another great organization. Some of those organizations I'll be talking about this week in social media. With the parents in grief, making sure we're providing them with the resources and what they need, utilizing child life services if you have that available. Even if your NICU doesn't have child life, often if you have a PEDS floor or a PEDS ER and they have child life, they will come and help you. Find out who the liaison is for you, because we also want to make sure that we're acknowledging fathers and siblings and extended family too. There are some great books. These are just 2 that I have personally read that I put on this slide, but many out there. I have in a book that had paper pages, put footprints in the book, and then we wrote a little note to the sibling in there. So it was like the other sibling, the sibling that passed was giving it to the other sibling. So great opportunity to do something special with that. We've put it on balloons, so kind of footprints on balloons. It made it feel a little less like medical for the child. But Child Life Services will have great resources for this. As the family goes home, there are opportunities for many organizations out there. Again, the chaplains, grief counselors, hospital support services. Make sure you've notified the OB. I mean, that's a big deal, especially if the mom is within those first 6 weeks. The OB should really know what's going on so that as the mom comes in, they can also help monitor her. There is a lot going on for dads and siblings here. I think that dads often can get kind of left behind, so making sure that you've offered resources to them as well is going to be really important. We're going to transition into what staff can do here. So all that, those are resources, kind of how we can help families. And now I want to talk a little bit about how can we help nurses and staff. So immediately following a death, there should be a quick debrief. We call these hot debriefs, where we did them kind of right away in a different room, especially if a code was involved. What went well, what could we have done differently, what are key takeaways. and really reviewed those factual events. We clarified any medical details. We talked about the emotions of it right there in the moment. But then a week later, or 5 to 10 days later, having another time outside of the unit to gather. We offered them via Zoom, or people could call in, and in person, where we had more of kind of a grief process, where we really talked about some of these questions that we asked there. What have you experienced since this death? What will you remember most about this family? How are you taking care of yourself? And we talked about grief strategies, coping strategies. We went through resources. We also talked about people coming in that weren't at the moment of death but had taken care of the baby, especially for a long-term kid. We had a baby once that had been there for about 6 months, and that never could get off 100% oxygen, and the lungs were just getting worse, and the parents did choose to withdraw care. And so when that happened, other people who had been primary caregivers for that baby came in as well to the emotional debrief to really process kind of what we were going through. And that situation was so unique, and I really think that it circles back to the idea of the parents and their choices and how we can support them through their choices here. But debriefs allow us to help kind of prevent some of this compassion fatigue and moral distress that we experience. So compassion fatigue is that emotional exhaustion from repeated exposure to suffering, whereas moral distress is knowing the right action but unable to carry it out. This can lead to burnout that's physical, mental, emotional. Naming these experiences, having an opportunity to talk about it, especially with those that understand it. This is just one resource actually from Scotland, dealing with an unsuccessful neonatal resuscitation. Those are really hard too. I've been in many of those. So there are resources out there if we're willing to use them. Ongoing self-care, this is just something I found online, but really it's hard. It's hard to do self-care, especially if you jump right back into work the next day, or you have a family, or you need to go on in other ways in your regular life. One thing I think is important to think about is having your unit have a policy on kind of what you're going to do for the next shift. So let's say I was taking care of the baby who passed. The next shift I can choose via this kind of assignment request piece of paper, something such as, I want to be in a different area of the unit. I don't care where I am. I would prefer to have a gainer grower team. I'd prefer to have a high acuity team. I don't care type of thing. So that as you ease back in, typically everywhere I have worked is when the baby has passed and the family has left and the baby is at their final resting place in the hospital, we could go home. And I've never, I don't think, experienced where we couldn't, where maybe the staffing was too busy. Of course, it's something you check in about, but that's also really helpful after this. It's so tricky, and I've done it as a charge nurse, a resource nurse, an admit nurse, where you have to just walk into another room and smile and go about your day. So that is very tricky. I cannot recommend enough finding your self-care that is going to help you through this. Many hospitals also offer therapy services, and those people are usually trained to help healthcare workers. So I recommend that, whatever it might be at your facility. So this was a brief overview of death and remembrance in the NICU. This is the most sacred work, right? We hold both life and loss in this weird balance, sometimes in the same shift. So as we think about all the babies that have passed this week, we honor them that are no longer with us. We honor the families who carry their memory, the nurses who walk alongside us, who carry their memory in their hearts. Are so many I could sit here and tell you about. And it's just, again, it is a privilege to walk through this with a family and walk alongside them. It is a privilege to take care of these babies at the end, but it is so hard not to let that go. So I see you and I feel you, and I hope that you will practice your self-care and know that you can always reach out to me. And if you have any questions about any of the programs, I'll see if I can find you as many resources as I have available. I will be making a document this week to collect them all. So if you want a document about some resources you could bring to your unit, let me know. Otherwise, I will see you next week for the 5th Tuesday of September and the wrap-up of NICU Remembrance Week and NICU Awareness Month.